In this video, we'll do an exam review on the acquired conditions causing lower motor neuron disorders causing muscle atrophy and hypotonia. The peripheral motor nerve, which arises from the brainstem, lower motor cranial nuclei, and anterior horn cells of the spinal cord. These two, cranial nerve nuclei and the anterior horn cells, are the lower motor neuron, and they are controlled by the corticobulbar fiber and corticospinal fibers to the anterior horn cells of the spinal cord. And from the anterior horn cell of the spinal cord arises the peripheral nerve, which mainly contains alpha and gamma motor neurons. Alpha motor neurons ramifies the extrafusal fibers, is thick and fast connecting, and a gamma motor neuron ramifies the intrafusal fibers, is thin and slow conducting. Causes of acquired conditions causing hypotonia, trauma, tumors, infection, diseases of the peripheral nerves and muscle disorders, myopathy, neuropathy, causing lower motor neuron lesions. Now the clinical features due to lower motor neuron lesion. Interruption of alpha motor neuron causes flaccid paralysis and muscle atrophy, and interruption of the gamma motor neuron causes loss of muscle tone and hyporeflexia. Combined effects of interruption of alpha and gamma motor neuron produces flaccid paralysis, muscle atrophy, hypotonia, hyporeflexia, fasciculations, fibrillations, and a negative Babinski sign. These are the features of lower motor neuron lesion. And also there occur denervation, hypersensitivity. And what's denervation, hypersensitivity? The denervated muscle becomes hypersensitive to small amounts of acetylcholine. Now some of the acquired causes of lower motor neuron disease. Number one, botulism. Botulism in children causes floppy baby syndrome, and in adults it causes symmetric descending paralysis. So how does it do it? Clostridium botulinum neurotoxin blocks the acetylcholine release from the presynaptic terminal and block the neuromuscular junction. This is a black shadow, shows a blockade of the acetylcholine release from the presynaptic terminal, and this occurs 20 to 30 hours after eating food that is not reheated properly. So it causes symmetric descending paralysis and autonomic disturbances, and cranial nerve involvement causes dysarthria and dysphagia, and the eye features are diplopia, drooping, and dilated fixed pupil, which is poorly reactive in 50% of cases, and death due to respiratory failure. Paralytic ileus with severe constipation is also a feature of botulinum. Now the next disorder is poliomyelitis causing lower motor neuron lesion. The virus attacks the anterior horn cell causing lower motor neuron lesion. Next is myasthenia gravis. Myasthenia gravis is an autoimmune disease that causes asymmetric descending weakness of the skeletal muscle due to decreased acetylcholine receptors at the neuromuscular junction. So botulinum causing symmetric descending paralysis, whereas myasthenia gravis causes asymmetric descending weakness due to decreased acetylcholine receptors at the neuromuscular junction. Acetylcholine esterase is present at the site of action and stops the muscle contraction. Acetylcholine esterase act on the acetylcholine when it's produced, and it converts it into acetate and choline. So here it is. This is the acetylcholine, and this present here is acetylcholine esterase. Acetylcholine is released from the presynaptic terminal, and the acetylcholine receptors are present postsynaptically. So there is decreased number of acetylcholine receptors due to antibodies which destroy them. So in myasthenia gravis, there is downregulation or reduced acetylcholine receptors. Antibodies against the acetylcholine receptor and muscle kinase antibody postsynaptic nerve terminal, and they block and destroy the receptors and damage membrane postsynaptic. Now, different types of myasthenia gravis. One affects the extraocular muscle, or it may be generalized, causing asymmetric muscle weakness. Weakness increases with repeated use, and it's more in the evening and improves after rest. There occurs snarling, a smile, dysphagia, normal reflexes in myasthenia gravis. There is positive tensilon, and there is 10 to 15% decrease in action potential amplitude. Repeated nerve stimulation increases the muscle weakness. An MRI of the thymus shows hyperplasia, germinal centers, and muscle-like cells. Treatment of myasthenia is pyridostigmine, immunosuppression, plasmapheresis, IV immunoglobulins, and thymectomy. Now, Bell's palsy. Bell's palsy is lower motor neuron type of facial nerve lesion that is nuclear and infranuclear fibers of the seventh cranial nerve are involved, causing lower motor neuron type of lesion with hypotonia, hyporeflexia, and weakness of the ipsilateral side, the face, both upper and lower face, because facial nerve supplies the same side of the face. Next is ALS, amyotrophic lateral sclerosis. The lesions in ALS are both upper motor neuron and lower motor neuron lesions. So in ALS, there are mixed lesions without sensory lesions. There is defect in the superoxide dismutase. Now, Brown-Sequard syndrome or hemisection of the spinal cord has clinical features of ipsilateral upper and lower motor neuron lesions. Lower motor neuron lesions with flaccid paralysis at a level of the lesion, and upper motor neuron lesions below the level of injury. So these two disorders, ALS and Brown-Sequard syndrome, have both upper and lower motor neuron mixed lesions. Now, myopathy. Stretch reflexes decrease in lower motor neuron lesions, but stretch reflex remains normal in myopathy until when? Until late in the disease. In lower motor neuron lesion, the weakness affects distal muscles more than in the proximal muscle, and there are fasciculations and early atrophy. Whereas the myopathic weakness affects the proximal muscles and is symmetrical. The myopathic weakness is due to the decrease in the number of muscle fibers due to dystrophies or inflammatory myopathy or myopathic necrosis. And in myopathy, on EMG, there are decreased action potential voltage. Other diseases causing lower motor neuron type of features are amyloidosis, sarcoidosis, multiple sclerosis, Guillain-Barré syndrome, and diabetes mellitus.